right, welcome to Fertility and Fibroids with Dr. Lauren Sundheimer. I'm going to pass it over to Dr. Sundheimer.
Hi, everybody. Thank you so much for being here today. Um, Great time to get awareness and learn more about fibroids. It's very, very common, as we're going to discuss. And I think we have some slides, but I don't see them up right now. But we'll jump in just a moment. But thank you guys all for coming. Kindbody, if you don't yet know already, is a large fertility benefits employer, or fertility benefits provider, as well as offering services. And so I am Dr. Lauren Sundheimer. I am a double board certified OBGYN and reproductive endocrinologist and infertility specialist. And so this is what I do. I help people get pregnant. I talk about fibroids. I talk about reasons for infertility and all these types of things. And so having you come today is the hope that we can kind of give you some information and then also be a resource to you to be able to then come and get help. So we are here to deliver all sorts of fertility care to all sorts of people. We have great success rates. We have amazing technology. We have beautiful clinics. We have so many things to offer you. But really, our hope and our goal is to change the landscape of how fertility care is provided. We want to do this today, tomorrow, the next day, one community at a time, one baby at a time, one couple, one single individual, to anybody and everybody. And that's really what we're here to do. So in kind of more of the nitty-gritty details that we offer, we do everything from fertility assessments, we do in-person and virtual consultations, we do fertility preservation, such as like egg freezing, sperm freezing, embryo freezing. We're really focused on helping pregnancy and family building in the LGBTQIA+ communities. We do male reproductive health, female reproductive health, genetic testing. So we really do kind of all of it. We have fantastic support services as well. We have something called our Kindbody 360 program, which offers a lot of counseling and support for mental health, for certain specialized groups, and we do nutrition and focus on certain more predisposing conditions to fertility and how we optimize that, mental health, etc. So we're here from you from the beginning and all the way through. We do pregnancy counseling, postpartum, all of these different things, and we're just here to be your ally throughout. But kind of jumping into some more of the details in terms of infertility and fibroids, which is why you're here today. As far as like a very basic definition, infertility is defined as 1 year of trying to get pregnant without being able to get or stay pregnant. And that's age dependent. So if you're under 35, we give you a year. If you're over 35, 6 months, because really infertility is very age dependent. And so we want to make sure that we're not spending a lot of time if it's not working. So that's why if you're older, we give you less time of trying on your own before we really recommend intervening. And it's very common. 1 in 6 adults are infertile. And it's not always due to the female. It's sometimes due to the male, sometimes due to the female. And it's about a third of the time male, a third of the time female, and then a third of the time both. So very common, very something that is you're hearing about more and more, but something to be aware of. And fibroids can also impact that. Next slide, please. So, as I mentioned, 1 out of 6 adults in the world will have infertility. And fibroids are one of the more common conditions that we see, in addition to PCOS, which stands for polycystic ovary syndrome, and it has to do with irregular ovulations or lack of ovulation, as well as endometriosis, which is an inflammatory condition where lining, excuse me, the material that's like the uterine lining grows outside of the uterus, and it causes a lot of inflammation, scarring, etc. But focusing on fibroids, which is our topic for today, in reproductive age women, they are very, very common. Up to 70% of women will have a fibroid in their lifetime. And it attributes to about 10% of cases where it's difficult getting pregnant. Fibroids disproportionately do impact African American women. We don't exactly know why, but it is a little bit more common. It can be up to 80% of African Americans. So this is a little pop quiz for you. If you are having any sort of heavy bleeding or a lot of pelvic pain or pressure, if you have really long periods that are also heavy, or a lot of pain with intercourse, the other potential question is if you have frequent urination or constipation or backaches or leg pain. If any of these questions are answered yes, and we say 2 or more, but maybe even 1, you might want to schedule a consultation. want to come in and have us check you out and talk about things. Fibroids are very common and can be associated with some of these things, but we don't know that we have them until we go looking for them. So some of the signs and symptoms are just what we described. So heavy, painful periods. It has sometimes partially to do with the location of the fibroid, and I'll talk about that in a little bit. But the fibroid can predispose you to having heavier periods or more painful periods. A lot of times, if a fibroid is larger, it can cause increased pressure in the pelvis because there's actually something pressing on the pelvic organs and structures. There can be something called what we say as bulk symptoms. So you have just kind of like a feeling of fullness or heaviness or pain pressure in that area. And then also, depending on if it's pressing on your intestines or your bladder, you may have difficulty using the restroom. And so sometimes people have to push on their bladder or do certain maneuvers or whatever to make sure that they're able to relieve themselves. And hopefully we can avoid that or at least get to the bottom of why it's happening. Not always fibroids, but it's one step of the evaluation. So, what is a fibroid? The very basic definition of it is that it's a benign growth. So, it's a non-cancerous growth. Sometimes you'll hear it referred to as a tumor, and a tumor is just a ball of cells, and that's what it is. But it's typically non-cancerous. It's a smooth muscle cell that's a ball of cells that forms from the muscles of the uterus. And like I said, we don't know why Black women are higher risk. Sometimes they do present later stage. So if this is a population that could be you, just something to keep in the back of your mind. But they're very common, as I said, and they can have a lot of just life impact, but also reproductive impact. We'll talk about, the ability to get pregnant, stay pregnant, but even later into pregnancy, there's increased risk of miscarriage, of potentially preterm delivery. Sometimes, depending on where the fibroid is, you can get more pain in pregnancy. It can grow in pregnancy. It can cause the baby to be in a different position and need a C-section. So there are a lot of things that can make a difference. And knowing if you have a fibroid and the size and, information about it is a great step in being an advocate for your health and fertility. And like I said, they're super common. So good to know where you're at. So how do fibroids impact fertility? So just to kind of start off, they don't always impact fertility. So breaking it down, there's different types of fibroids that you can have. You can have something called a subserosal fibroid, which is on the outside part of the uterus. You can have a fibroid called intramural, which is in the muscle wall of the uterus. Or you can have something called a submucosal fibroid, which is in what's called the mucosa or the lining part of the uterus, which is where an embryo or pregnancy would be. Typically, fibroids that are the most impactful for fertility are ones that are called cavity distorting fibroids. So the inside part of the uterus where a pregnancy goes is impacted. And that kind of makes conceptually sense, right? If there's a fibroid that's sticking in to where a pregnancy wants to implant, that's not a normal blood supply. It's not going to result in a normal, healthy pregnancy as we would hope. And so that's when it can become impactful. If it's a small one and it's on the outside of the uterus far away, a lot of the times we ignore those types of fibroids. So the fibroids that impact fertility are a very specific subset. And typically it's when they're either very large, they enter the uterine cavity. Sometimes they can be, blocking a fallopian tube, for example, and that can be impactful. So there are nuances to it. But even though fibroids are common, a lot of the times we just note them, we watch them, and we keep on going. There are certain times where they are more impactful. And like I said, if it impacts the ability for the sperm and egg to meet or for fertilization or implantation, then we would probably want to intervene. So fibroids are diagnosed most classically through, we can do like an abdominal and pelvic exam, but a lot of times, especially this day and age, and especially at a fertility clinic, we do vaginal ultrasounds. And we can typically see that with an ultrasound. It looks like a little whirl, we call it. It kind of looks like a ball. And depending on the size, you can sometimes see it very obviously, maybe not so much. But we do this all day, every day, and we're very good at detecting them. An MRI is another test that we can do that can help us to be able to get more of the characteristics of what the fibroid is or where its location is. There's something called a FIGO grade that, for those of you who are familiar, may know more about, but that just kind of breaks down those typical subcategories of fibroids a little bit further, and we can get more information with more testing. And then blood test is listed on here. That's not really diagnostic for a fibroid, but it can tell us information. So for example, if you have a blood count done and your levels are low, you have anemia, you have heavy periods, it might kind of suggest, oh, maybe we should go looking into potentially a cause of why you have this. And, maybe there is a fibroid, maybe we can do something about it. So as far as the treatment options, there are a variety of treatments. Some are pregnancy friendly and some are not. So it depends on your goals. The hormone therapies that are available, sometimes it's as simple as birth control pills, and having that hormone and kind of regulating the periods and things like that can help. That type of treatment does not necessarily help with the bulk symptoms I was mentioning, so the pressure and the pain and that type of thing. But the medication and the hormones, if it's more of just like I have a heavy period and I want to try and control it, then that can help with it. The most definitive way to treat a fibroid would be to surgically remove it. And there's different ways that that can happen, again, depending on the location of the fibroid. So if a fibroid is really large, they may recommend doing something called an abdominal myomectomy. So myomectomy is the term of fibroid removal, and an abdominal approach is where we use like a C-section type incision or an incision in your belly to then really get good access to the uterus to remove the fibroid. Sometimes that's a little bit not always done because it's a big surgery, it's invasive, and granted, any surgery is invasive, but having a big incision is a little less done now because we have really great technology to do more minimally invasive surgery. So you can have a robotic myomectomy or a laparoscopic myomectomy, and there's certain people who really focus in on that and then can, really get to the bottom and get all those fibroids out, especially if you have multiple or depending on the location. Some people are better candidates for certain approaches than others. So if this is you, I would recommend talking to your physician and making sure that you come up with a great plan and approach and what works best for you and your uterus. A lot of people sometimes get scared because they're like, oh, I have fibroids, and I know my aunt had fibroids and she had to get her uterus out. And so that's a beautiful thing. We have uterine sparing surgery. So a myomectomy just removes the fibroids and leaves your uterus intact. You can still hopefully get pregnant with your uterus. A hysterectomy is also the definitive treatment, but that's removing the whole uterus. So if that's not something you're interested in, then maybe ask about a myomectomy to see if you would be a candidate for that. There's also some other types of procedures and treatments that are out there that are a little bit newer. There's radiofrequency ablation and things like that. Not all of them are necessarily safe for fertility or for your desire to get pregnant in the future. So just make sure that you do let your doctor know if fertility and future childbearing is something that you want. And if, let's say, you get the fibroid out, a lot of women just having that fibroid removed, especially if it's that cavity distorting type of fibroid. So again, I'm talking more of like a submucosal fibroid that's inside the cavity of the uterus, or an intramural cavity fibroid, an intramural fibroid that has a portion of it in the cavity or it pushes the cavity, then those would be things they typically want to remove. And sometimes just having that removal can increase your chance of pregnancy twofold. So that's huge. If you can double your chance just by having the fibroid removed, that's big. That being said, surgery is not without risks, right? There's risks from anesthesia. You can get scar tissue. If we're doing an incision in your uterus, that is also going to weaken that muscle of the uterus. And so you sometimes, depending on how extensive the surgery is, may need 3-6 months of recovery to really get your uterus back to a safe place where it could carry a pregnancy. The other thing that you should know is that depending on, again, the type of surgery, how extensive it was, you may require delivery via a C-section when it is time for you to have your baby. So there's lots of factors that go into it. But even if you don't get pregnant on your own at the end of it, we're here to help you. So we can help you by, doing something like IVF. We can help you with fertility treatments. If you have a fibroid and you're worried about your fertility, because you do need to spend a few months recovering after, if we're able to safely get to your ovaries, we can do egg freezing or embryo freezing or what's called fertility preservation before you have your surgery. And that's something that I'll recommend to people a lot because I want you to have options. And so we can get those eggs out, we can freeze the eggs or the embryos and have them ready to go. You have your surgery and those are frozen in time until you're ready to use them. So by the time you're recovered a couple months down the road, you haven't lost that time in the fertility timeline. We still have them ready for you. And so we can just plan to put them back as soon as you're cleared. Next slide, please. So a little bit about IVF. It stands for in vitro fertilization. And it's similar to what's called, a lot of people maybe are familiar with egg freezing, and it's the first half of egg freezing is IVF. So you take daily hormone injections to grow the eggs in your ovaries, and then we remove those eggs from your ovaries if you're just doing egg freezing. If we're doing IVF, then we would fertilize those eggs and let the embryos grow. So the process, like I said, is the same up until the egg retrieval, and then we either freeze eggs or we fertilize and let them grow and freeze embryos. And so we can do that fertility preservation if you're planning surgery or whatever may be the case. And we often freeze embryos anyway because we can do genetic testing on embryos. And so that's a huge benefit because, especially in women as they get older, not only does the number of eggs we have go down with time, but the quality goes down as well. And so you can have, higher rates of what's called aneuploidy or genetically abnormal pregnancies that can lead to miscarriage or not having a pregnancy, etc. And so doing IVF with genetic testing of the embryos, we can know of however many embryos you create, which ones are going to hopefully result in a pregnancy versus not. And so we can do that outright. Again, if you have a small fibroid that we're not concerned about, it shouldn't really matter too much. We can either preserve your fertility and you have surgery if needed, or we just keep moving forward. But the process of putting the embryo back can be separate from the IVF or the egg freezing process. And that is called an embryo transfer. And that's when we then implant the embryo into the uterus. Next slide. So I feel like it talks kind of a lot about a lot of different things. Essentially, there's no magic formula for everyone. Everyone is different. I think this is a very nuanced subject that you do have to talk to your provider about because it really depends on the size and the location of your fibroids, or even if you have them, or if you should be worried about them, because really there's no right answer that I can just say applies to everybody because everyone is a little different. All fibroids are a little different even. So I think here at Kindbody, we're here to help you. We want you to make good decisions for yourself. I personally feel very strongly that information is powerful. And so coming in, see where you stand, if it's your uterus and if you have fibroids, if it's your ovaries and what's called your ovarian reserve, to see maybe if you have less eggs than somebody else your age, we can intervene, we can do things. And so just coming in for an assessment to kind of know where you stand, I think is really critical and key. And I'm happy to help. I'm based in Newport Beach. I actually go between Los Angeles to San Diego. And so I'm in Southern California, but I'm happy to help anybody. And I'm happy that you guys were here today. I think we might be done with our slides unless there's anything else that I missed. Maybe we can open it up for some questions. Oh, sorry, never mind. Here we go. So this is how you can do that one-on-one consultation. So like I said, I'm a fertility specialist. You can book an appointment. We talk about things. We go into the nitty-gritty of you, your history, your goals. And then we come up with a plan based on that. And so it's very personalized. It's not a one-size-fits-all approach. We then would, do an ultrasound, blood test, all of these different things to find out where you should go, what your trajectory will be. And then, of course, we do a follow-up and then plan from there.
Yes, amazing. Thank you so much, Dr. Sundheimer. So again, if you do not have a benefit with your employer and you're just coming in and you want to get evaluated, you just go to kindbody.com and schedule. If you are coming in from an employer who has the Kindbody benefit, then you would go to kindbody.com/activate, get your account activated. And actually somebody asked how they would find out what's included with their benefit. So you would do that. You would go in and activate. And then there is a portal where you can message our team and ask them for your benefits guide. You could also email employeebenefits@kindbody.com and find out there as well. So now let's get to some questions. And please, if you do have more questions, send them in the Q&A or send them in the chat and we will get them answered. We have a few minutes left with Dr. Sundheimer, so I want to make sure we get a couple of questions answered. So number one, we have a great question here. This person is asking about after fibroid removal surgery, if there isn't a cut in the uterus, is there an ideal time to get an embryo transfer or implant? Is there a sweet spot? I imagine you may want to wait a bit after the procedure to do a transfer. What are your recommendations on that, Dr. Sundheimer?
I think it's a good question. Essentially, if you're having a fibroid removed, there's some sort of removal and some disruption of if it's inside. I think maybe you're referring to if there's not a cut in the muscle, if it's a submucosal where we remove it from the lining, you're disrupting the normal lining of a uterus. So my approach is usually if it's something significant, we want to give your embryo the best chance of implanting. So I usually will recommend you have a reset, let your lining heal, and then maybe the next month or so, if it wasn't super extensive, you could potentially have an embryo transfer, but I wouldn't usually do it in that same cycle just because the procedure of removing a fibroid disrupts the normal lining, and we don't want that to be disrupted for your embryo.
Yeah, that totally makes sense. Okay, and then this one, similarly, if fibroids are small and on the sides of the uterus, is it possible for it not to interfere with fertility and pregnancy?
Absolutely. Yeah. I mean, so those are called the subserosal ones on the outside. And if you're trying and you never had an ultrasound, you would never know you had it. It depends on the size, but if they're small, you're probably asymptomatic. You could have had it for a long time and never known. Usually they're not impactful for pregnancy.
That's good news. Okay, and then some other questions on diet and lifestyle. I know with other gynecological conditions like endometriosis, PCOS, diet and lifestyle can impact severity. Is there an element of that with fibroids?
Unfortunately, no. I wish I could be like, eat this and you'll have your fibroid go away. But no, it's because it is just a multiplication of a smooth muscle cell in the uterus. It just can happen. And it's something that it can grow with time. It's not anything that you can really do lifestyle wise, but there is a little bit of a thought that they are sensitive to estrogen. And so it potentially could grow in pregnancy, for example, but that's not always the case. Some do, some don't. But there's really nothing that you can do lifestyle wise to prevent growth or make them go away or anything like that.
Hmm. And then similarly, do we have any idea what causes fibroids in general? No idea.
I mean, it's just same thing like cancer, like there's a cell that just turns, right? And for whatever reason, it's more common in certain people than others, but not that I know of as a specific reason.
Okay. And do we have any idea how much they grow on average per year?
Some people can have a stable fibroid for years and years and years and years. Some people will have more growth. Um, Most of the time, it's a rather slow growing process. If there is a rapid growth, and that typically could be something maybe a little bit more concerning, you might want to talk to your gynecologist if you're noticing something or you're having really severe sudden change in your abdominal symptoms potentially. But sometimes they grow, sometimes they don't. There is medication you can take to try and shrink them, but that again is not fertility friendly. And since we're focused on fertility, I didn't really get too much into it. But for those of you who are interested, you can talk to your GYN.
Yeah, absolutely. And actually, somebody's asking here about insurance coverage. So, yes, that's true. If your insurance only covers reproductive health and not specifically fertility, infertility, it's possible that they don't cover Kindbody because we don't offer gynecology anymore unless you're with an employer specifically. So it is a little bit complicated, but I would imagine that our team could help you navigate that if you are interested. So one last question just on fibroids and fertility specifically. Is there, would you say that there is a need to see an REI if you go to your gynecologist and you do have a fibroid and you are trying to get pregnant? And there's no necessary, we said there's some fibroids that won't impact fertility and some that will. Would you recommend that anyone who has a fibroid and is trying to get pregnant come in and see you or us or a reproductive endocrinologist?
I think, like I said, knowledge is power. I think coming in and talking to somebody who does fertility day in and day out, maybe you can get a little more nuanced opinion on things. Obviously, there's a lot of OBGYNs that are experienced in this and are very capable, right? Like this is a general gynecologic condition. It's just in certain instances where it can impact, fertility that we are a little bit more aggressive. But if you have any question, I would say absolutely come in. The OBGYN, they're delivering babies and they're doing surgery. There's all sorts of things that they're doing. But my sole purpose is fertility. I do this all day, every day. I'm not delivering babies anymore and things like that. So I think that is one of the benefits to seeing an REI is that we are purely focused on fertility. And if that's your goal, then we can definitely help you through that.
Yeah, absolutely. That makes sense. And actually, one more question before we wrap up, because this is somebody who's live on here. So after a myomectomy, how quickly could they grow back? Is there like, at what point are you concerned about, I guess, a resurgence or?
Yeah, I think that's a great question because the goal of a myomectomy is to remove the whole fibroid and to completely remove it. So hopefully it doesn't come back. If you eliminate the whole thing, it should hopefully just recover and resolve and be done. A new one could pop up. If there was a partial part of it that was still there, it could come back, but the hope is usually to kind of remove everything.
Yeah, perfect. That makes total sense. Well, thank you so much, Dr. Sundheimer. That's all we've got for today. If anyone has a question that comes up that wasn't answered today or that you think of later, you feel free to send us a DM on Instagram and I will send that over to Dr. Sundheimer and get it answered for you in case. And we're so excited to have you here and we're so happy that you're taking an interest and being proactive about your reproductive health. And we'll see you next time.
Yes.
Thank you
Thank
all
you
so
all. Feel free
much.
to follow me on Instagram too. Send me
Yes.
messages, but I'm wishing you all the best. Thanks, guys.
Thank you all. See you soon.
Bye.